Today we are in the Type 1 Diabetes Symposium, and today we have with us Dr. Sudesh Damodaran. He is a consultant diabetes and endocrinologist, Sri Ramakrishna Hospital, Coimbatore, honorary consultant in Derryford Hospital, Lima, Vice President Endocrine Society, Executive Council Member Endocrine Society of Tamil Nadu.
No.
He's won various awards and honors, the Donald D. Elsevier International Scholar Award, Diabetes Awareness Initiative Award in 2014, and he's had various publications to his name. Today he is going to speak on endocrine issues in type 1 diabetes. So,
thank you for that. Very kind of you. I understand. I know that you're outstanding person. Sure. Well, that's the hope. That's the hope. We live in hope, Okay. So I'll keep it short. Good morning, everyone, and thanks very much for the wonderful opportunity. I hope there are people seeing online. So there should be just a build-up. It's supposed to be a type 1 diabetes symposium, and the initial talk supposed to be hypoglycemia, but I understand that has been spoken already. So now the task what I got is next 20 minutes or so is about other endocrine issues in type 1 diabetes, what you should look for in a type 1 diabetic when you got in front of them, front of you in a clinic, so they will be already challenged with a lot of psychological issues, if you like, with the challenges that they face psychologically about their diagnosis and what do they do with it. Along with it, I think, can I have the play mode? Help here. Can you come and help? This one? Yeah, okay, I think should be okay. So, here? Okay. So, a type 1 diabetic comes to your clinic. I'll just put up 4 or 5 clinical scenarios. So, recurrent infections was the one, and then he presents with vomiting and giddiness and diarrhea, and this is a typical type 1s. They have vomiting and diarrhea, so you should think of DKA and other things as the first life-threatening infections. Also can contribute, but apart from that, diabetic gastroparesis and everything happens. But in a type 1 early stage or at any stage, for example, the glycemic control is very poor and hyperpigmentation is identified in this patient. What is the possibility? There is early signs of retinopathy indicating a microvascular disease. And what is the possible diagnosis here? It is Addison's disease. Yes, it is a hypoadrenalism. And what happens is in type 1 diabetes, the patient with Addison's disease has got a huge challenge of hormone replacement throughout their life. Along with insulin, there is another drug that has to be given is steroids, and it compromises counterbalancing insulin and glucocorticoid and glucose metabolism. I'll just come to that briefly in a minute. So epidemiologically, it is there. You have to open up your eyes and look for it. And the type 1, you have to work for hormone condition, especially when there is a fluctuating blood sugars. So you look for the other causes, and you have to look for a condition called celiac disease as well. Anti-gliadin antibodies or IgA antibodies you can check for just for a celiac disease when you have a fluctuating thing. And then another one to do is a B12 level. So cortisol is one of the things that you should consider doing it. The incidence is almost about 10.8%, so you have to open your eyes and just look for it. And then concurrent type 1 and AD, increased risk of death. That is the reason that you should understand this disease and treat it, and it is another hormone that has to be given. So this is the challenge. You have got a blood sugar, insulin, and then cortisol goes in, and then insulin resistant, which leads to metabolic stress. So the high probability of Addison's disease in type 1 than the control indicating it is another hormone condition that needs to be looked into. What are the key features? You look for infection, as I presented the case, multiple diabetic complication. I have also mentioned in my talk. saying that it can lead to microvascular disease, and then diabetic retinopathy is one of the common things. So you should know this before handling it. And then prescription of thyroid and anti-thyroid drugs and prescription of glucagon is also should be considered because of hypoglycemia. Now, main causes of death in these patients when you have Addison's disease, as I mentioned, type 1 complications can happen with microvascular disease, and cardiovascular disease is a macrovascular complication. Infection, sepsis, and adrenal failure, when you don't diagnose or people manage it wrongly, then it will lead to adrenal failure. Now, the higher risk of Addison's disease in the patient that lead to higher mortality, as I mentioned, the cardiovascular disease. So you have to improve the type 1, manage it and prevent the complication, and appropriately replace the glucocorticoid in the similar manner. So that brings the second case scenario in a middle-aged type 1 diabetic woman presented with fatigue, sluggishness, and weight gain. A1C is 7.9. The thyroid was swelled up. What could be the reason for symptom? And there's for the thyroid itself, I got another case scenario of a 15-year-old type 1 presented with delayed puberty and short stature and recurrent hypoglycemia. So this is an indicator in a type 1. Yes, they will have erratic blood sugar control, but you have to open your eyes. It's a hormone condition. The insulin is a hormone. It got a deficiency of the hormone, and that hormone will lead to hypoglycemia. So the height is 3rd centile, standard deviation, he is a very short stature, that has got a dimorphic anemia as well. So puffy face, typical of a hypothyroidism with a TSH more than 100, and you got a FSH which is in the higher end, indicating other endocrine conditions has to be looked into as well, like hypogonadism, which I'll come to that in a minute. So this patient was started on thyroid hormone replacement, but had a weight gain, and then height was increased, entered puberty, and glycemic control keep on fluctuating. The insulin requirement has gone up in a big way. So we have to open our eyes, just look for the thyroid disease. It is easy to do. Even Western countries and places in big hospitals, you have to have a guidelines, but in India you can just get it done for 300 to 600 rupees of thyroid function. There's no harm in doing it in a type 1 diabetic, possibly every 6 months or 1 year, because you might pick up some conditions of autoimmunity earlier. So it can lead to hyperthyroidism or hypothyroidism, and also you have to open your eyes again just for postpartum disease as well. And I mentioned and talked about celiac disease. So type 1 and thyroid disease, how common it is. So antibody prevalence is there, TPO antibodies, and then the treatment is needed with thyroid hormone is needed, and also it reaches almost 50%. So you have to do a thyroid function. You no harm in spending money for that. And these are very common disorders, and male to female ratio, we know about that very well, and it affects almost 5 to 10% of the general population, and we need to have a the long-term follow-up suggests that 30% of type 1s develop autoimmune thyroiditis. That is a huge number. So you got in your clinic about 100 people, 30 people will have type 1 diabetes. So you have to just make a diagnosis, otherwise it will get missed, because type 1 people won't do a thyroid function as a general practice or something, you'd get missed. So you have to get it done, and there are a lot of Indian data for it, but especially this is mainly for type 2s rather than type 1s. But the prevalence of disease is very high. So even for type 2s also you need to get that done, as this thing, the prevalence, it is like what they label as a double epidemic with diabetes and thyroid disease. So it is highly prevalent in all the cities in India. There's been work done on that, so clearly indicates that we need to check for the anti-TPO positivity in a type 1 patient, which will give you the diagnosis. And there are a few things that we need to look into, and especially, as I mentioned, this is all for type 2, so it's hard to do for a type 1. But what is the mechanism? So you look at the TSH receptor antibodies, and then there are challenges. It comes into with hepatic glucose output, and then it will lead to either thyroid storm, from thyroid point of view, you have to be very, very careful if you got a poor blood sugar control. And then hyperthyroidism, that will lead to hyperglycemia. So a type 1 diabetic can also have hyperthyroidism as well. I showed you a case of hypothyroidism, but the GLUT2s on the liver, that will lead to hepatic glucose output, that will lead to hyperglycemia. So hypothyroidism, on the other hand, will also decreases the peripheral tissue glucose disposal, that will again lead to decreased GLUT4. GLUT4 decrease means insulin resistance goes up, and then there is a challenge of blood sugar going up and down. So association, as I mentioned, type 1 significantly associated with hypothyroidism, so we should get this test done without fail. So as I mentioned, that hyper and hypo is there, and that will lead to quite a lot of challenges in the other side, especially the type 1 diabetic. So the prevalence is there. Current recommendation, this is mainly for Western countries, because you in India we can do spend 300 rupees, or just even TSH, just TSH doing is alone is enough in a type 1 every 6 months or so. We need to check for the antibodies at least once, and make sure if it is strongly positive, we can do it much more frequently, as I mentioned, every 6 months. This is the third case scenario. I'm in a gynecopy for an infertility consult for past 1 year, and periods are irregular, infertility status. What happens is the condition called polycystic ovaries, again an epidemic in a young woman. So the type 1, it is very well documented that poorly controlled glycemia is so menarche is also delayed in these people, and proper studies have been done is showing that menarche and menstrual disturbance happens in a young woman with the type 1 diabetics, and that has got an impact on the theca cell and granulosa cell, that will lead to challenges in the sort of periods. And here it shows that the duration of type 1 diabetes, and also the onset of menarche, and also the periods, and everything gets affected with type 1 diabetes. So there is a definite link that has been demonstrated. So hyperandrogenism is one of the things with the polycystic ovarian syndrome in type 1 diabetics. It's so very well documented. It's almost present in 40% of type 1 diabetics women. So we should be again monitor and just do a good workup for these kind of people. They won't have a typical sort of morphology of a plumpy type 2 sort of features, but they will be having polycystic ovaries. They may not have an imaging polycystic ovaries, but you have to look for hyperandrogenism symptoms, and also sometimes you have to do the hormone levels. So pooled prevalence of PCOS, roughly almost 25%, and very high in type 1 diabetics. It will lead to subfertility, and androgen excess should be included in the current guidelines to check for it. Even if you don't do the levels, I think you should look for a clinical features that will lead us to a diagnosis. So this will hyperinsulinemia, that will lead to polycystic ovaries. So that brings forth. So I mentioned about PCOS. You also need to take care and just look for it. And then another thing is for male 33-year-old, A1C is 9.5. Is there a link between male infertility? It has got a direct, definite affection of erectile dysfunction. As I mentioned, the retinopathy, but erectile dysfunction also, it's a vascular disease. And for a type 1, we should be monitoring it and doing more about it. It is almost reported in 60 to 80% of the patients, and also with a duration of 10 to 15% of men in type 1 diabetic. So here there are quite a lot of challenges, and it will lead to vascular, and then leading to trabecular flow that will affect the erection. So, and there is another mechanism where it will lead to hypogonadism. So you have to look for hypogonadism features as well, that will be associated with type 1. But you need to work on it as like what you do for a type 2 patients. You have to work on it and get the diagnosis first before treating. So what I've done so far is last 10-15 minutes or so, I given the scenarios what we commonly see. What we see is in a type 1 diabetic, we should look for when the fluctuating blood sugar or hypoglycemia happens, you should look for Addison's disease, just doing a cortisol level. And I've shown you case scenarios for hyper and hypothyroidism both, and then you have to, for a young woman, you have to look for polycystic ovaries. Now, other than that, there are a lot of things which is uncommon, where these are all the common things what I mentioned that should not be missed. But the uncommon things you have to look for is a hypo parathyroidism, and then chronic mucocutaneous candidiasis, you look for the nails, and then adrenal we talked about, and primary hypogonadism. So in a young woman, it will lead to even premature ovarian failure, that kind of thing. It will be saddened to see those people. I mean, I don't know how frequently, but I see in my clinic the prevalence of premature ovarian failure has gone up slightly. Unfortunate thing for a young woman, but that has gone up. And we talked about hypothyroidism, and there is a autoimmune hypopituitarism as well. You have to look for it, but that is all very rare, but you can look for it. And some condition called lymphocytic hypophysitis can happen. And we discussed about malabsorption syndrome with celiac disease, and pernicious anemia is a B12. You have to make sure you check the B12 levels when there is a fluctuation of blood sugars, especially hypoglycemia, which will affect the absorption. And active hepatitis is also an autoimmune disease. You look for LFT subnormality. And vitiligo is a skin condition that you can have a look with your this thing. But those are the common things actually. Hypoparathyroidism, you have to get the diagnosis only by doing a calcium levels, and patient may be symptomatic, you can go for it. But the polyglandular symptoms of multiple endocrine neoplasia, it's a polyglandular type 1 and type 2. So adrenal, autoimmune thyroid disease, type 1, primary hypogonadism, insipidus, as I mentioned, in the pituitary involvement, if that happens, and then skin conditions of vitiligo. So if you have all this or a part of it, then you should suspect these rare conditions, and it will give you immense pleasure when you diagnose somebody. You can treat it. We can treat the calcium, you can treat the thyroid, you can treat the adrenal, you can treat the type 1, and the patient gets really better in front of your eyes. There are a lot of conditions you can't treat as a human being, as a doctor. You feel bad about it, but here you can do a better job when you diagnose it properly. So I will show you the clinical scenarios, which is APS type 1 is chronic candidiasis, hypoparathyroidism, autoimmune adrenal insufficiency. APS type 2, on the other hand, you should have an adrenal this thing. APS type 2, you will be seeing a lot in your clinic if you got a pool of your type 1s, and autoimmune thyroid disease, and then type 1. So here type 3 of APS is existing, excluding autoimmune adrenal insufficiency, hypoparathyroidism, and chronic candidiasis. So it goes on, but we should be making a clinical diagnosis. And see, I'll show you from my cases what it is, just to show in a young patients with the pigmentation and other things, you should suspect going for checking for adrenal. And here again, just checking adrenal is very, very important. These are all the people who type 1 going into checking for adrenal insufficiency, and involvement of mucus is also there in this patient. So I showed you 3 case scenarios, which was all very, very interesting. You have to make the diagnosis. Thank you. The next one is APS from infancy. So you can see the cortisol level is being 44, and you have to think these kind of babies. So whole point of education is, when you have a case of type 1, if you can't think of out of the box, you won't make the diagnosis. So then you do a blood test because of multiple hypos, you go ahead and do this thing. So after this kind of awareness, a doctor should try to make a full investigation of a type 1 patients, and then that will lead to a proper treatment of it, and so the fluctuations won't be there. Just a small word: when you have pregnancy as well, there are a lot of challenges when you have a type 1. So what I've done is, in the last 20 minutes or so, is to throw some light on the common conditions where type 1 diabetes associated with adrenal, and type 1 associated with thyroid disease, where hyper and hypo, and also type 1 diabetes with common things like polycystic ovaries and hypogonadism, and one other condition in a young woman of premature ovarian failure. That kind of thing you should think of as when there's a hypogonadism. And I've also touched based on polyglandular type 1 and type 2 and ABC, 1, 2, 3, 4, sorry. So with that, I stop this thing. I'm happy to take any further questions. Thank you.
Thank you, Dr. Damodaran, for the wonderful lecture. It was an extremely informative, exhaustive discussion on various endocrine issues in type 1 diabetes. And the take-home message here is always thinking out of the box. Absolutely. And looking for features, and then you find them.
Yeah.
Any questions?
No, thank you. Thank you. That's I'm thanking you because you entered in. Absolutely. That's okay. So markers. No, this is very interesting. I showed all my cases. This is hard to get. So if that is, it's a shame that we don't have a crowd. You know, when you see the pigmentations like that in a type 1, you go for an investigate. And hypoglycemia. Hypoglycemia is one of the things that consider. And then vomiting. People, when they are not a type 1 for a very long duration, if they got a very long duration and a type 1, then there can be gastroparesis. It's an autonomic dysfunction. You consider that. But here, then you should consider hypocortisolism. These are the signs that I can think of, apart from just being a woman. If there is a woman, then you will get a normally sign as the period. So getting a menstrual history is a very, very important thing. And of course, the skin lesions and everything will give way. But as madam was saying, it is your brain have to know this to see a patient and think and get a diagnosis.
I just have one question for you. Generally, we see many of these type 1 diabetic cases who are GAD autoimmune negative, so they fall in the type 1B.
Yeah.
In such cases, should we be following them up for MODY genetic testing to see if they could fall in the sulfonyl area or treatable?
No, I won't advocate that. I think if you got a clear indication of a type 1, going through a painful, it is not easy to get a MODY or anything done. If you know the C peptide is not there and it's clearly indicating a young type 1 sort of thing, then you don't need to put them in an unnecessary stress. On the other hand, if you think that it doesn't suit in with type 1, it is a clinical thing. You must have seen so many patients in your life, and there is no other autoimmune conditions in that patient. It is ad hoc, one-off, and patient doesn't look that sort of unwell, then you can go for this thing. You can go for, there are few centers does it free, I think, nowadays, so you can go for it. But if you ask the lab who's doing it, there will be a lot of overdiagnosis and people sending in the sample just like, oh, by the way, I want to diagnose MODY. And so it will be normally the case rather than the incidence is up.
Do you see a lot of cases of this mixed picture of obese children being diagnosed, as in the classical case of type 1 diabetes with recent onset weight loss and NDKA? But they are generally obese. They've been obese for a long time, and they have signs of insulin resistance. Do you see this kind of mixed picture?
Well, obese kids with insulin resistance, with a lot of acanthosis and other things, we see a lot. But your question is whether you're seeing an obese kid as a type 1.
Same thing as type 1, the first.
I don't see that well. That I don't have that much number to see or tell in my experience, or I haven't seen in my 27 years of more of obese individuals. getting type 1. But what happens is, if your type 1 kid is there with you, at some point, especially women, they get slightly plumpier when they go to 24 or 25, something like that. Then what you need to do is, you have to consider metformin for them if it's a type 1 as well, and that's a very practical point. Yes. So if you use metformin, you don't know the results. It will be amazing. So HbA1c 13, it will be 7 or 8, and there are a lot of idiots will say, oh, this type 1 that they are given metformin. Don't worry about all that. You just do a proper job and you will be well appreciated for the patient and also for yourself as being a good doctor. Thank you.
Thank you, my dear friend Suresh, for giving highly informative talk in this hello all. So we'll go on to the last topic of the day. So I am happy and privileged to introduce Dr. Archana Sarkar. She is a consultant diabetologist and director of Shraddha Center for Diabetes and Self-Care and founder of Udon, an NGO for underprivileged children, currently supporting 1,000 children. And she is the convener for National RSSD Type 1 Diabetes Task Force. She has more than 20 years of work in innovative diabetes care in the rural low resource setting. And she is also the co-author of ISPAT guidelines in limited resource setting 2022. Over to you, madam.
Okay, good afternoon, and thank you for this having the topic here in Diabetes India. After many years, finally every conference has a type 1 symposium, although we still do not have enough people wanting to learn about type 1 diabetes, and that is a challenge which we will take. I am part of the RSSDI type 1 task force, and the challenge is that one day we will take it to the last mile so that every child in every village is taken care of in the right manner. It's not just insulin, but so many aspects which are important. So I will just go very quickly. It's a short presentation, and it is mainly meant for people who do not always look at type 1 diabetes, because an average physician would be seeing very few patients in their daily practice, and diabetologists also. So people who have dedicated centers of type 1 diabetes, it's different, but people who do not, and it's just one few children or adolescents or adults they have, there's always a confusion on what is to be done, and so this presentation is mainly meant for them. So it's not just a science. I mean, we may know all the things in the textbook, what we want to do, how to initiate insulin, how to titrate the doses, how to monitor, we may know the CGMS, the pump, everything, carb counting, but that science is not enough, because at the other end is a person who is undergoing a lot of emotional, mental, social, physical trauma, and the caregiver is there. So this entire process is way beyond science, and unless we take care of the other side of it, the science part does not work. So it has to be complementary. It's an art and a science. So while we talk about insulin technology, regimes, pumps, CGMS, and carb counting, at the same time we cannot at all, it's not the soft side, it is the most essential part of type 1 care, and that is education, motivation, and counseling. So we just can't do without it, because it doesn't work. So type 1 education care actually starts with empathy, engagement, and empower. So unless we have empathy, I was just in the other room, we were talking about type 1 diabetes and its care. If you cannot step into their shoes, you cannot probably design an insulin regimen for them. I may know all the insulins in the world, but if my patient is a laborer who works for 350 rupees a day, and I want to give physiological insulin replacement to the laborer's child, and I do not want to use premix because that is not good for the child, then I have to be empathetic that that parent is going to lose time and money, so I have to fit their pocket, their time and their orientation, their education. But yet I will not compromise on the medical physiological replacement. So that is the kind of dedication that will come only when we are empathetic to our families of people with type 1 diabetes. Again, this is very, very important because everyone, we talk about individualization, we talk about not being glucocentric in type 2 diabetes. Individualization is absolutely essential here beyond the medical individualization. It is also about individualization from a total social spectrum. Right? So it's a very, very complex thing. So another thing I would like to say, if we do not have the bandwidth, I can understand every doctor would not have the bandwidth to do all this, then please send your patient to the nearest NGO, the nearest center where they can have all this. Because if they do not have empathy, if they do not have engagement and follow-up, if they do not have, they are not empowered with education and self-care, their life is only survival. Then they are not thriving. They are not growing physically, mentally, emotionally to become a normal citizen of this country, which is our goal, right? So it is not simply a task which is about giving medical care, but we need a team for that. So what I would suggest, anyone who is very keen on type 1 care, get educators, nutritionists, counselors. That is recommended in all the guidelines. But if we do not have them, for example, I come from a place called Aurangabad where we do not have these facilities, we created them. So we created coaches. They formed a bridge with the educators. So you can create coaches, you can have leaders with type 1 diabetes, you can have mothers of children with type 1 diabetes, caregivers of people with type 1 diabetes who can be trained and they can become your coaches when you do not have enough educators. So, but you cannot compromise without education, cannot compromise without nutrition guidance, we cannot compromise with not counseling. Because these are 3 pillars without which the best of technology, the best of insulins are not going to work. So once we have started the treatment, it's very important for good type 1 care is to maintain an inter-visit communication. What usually happens, why it fails often, is the doctor sees them between 2 problems. Severe hypoglycemia, DKA, patient is admitted. What happens in between? So unless there is a bridge in between 2 hospital visits, and that communication channel will keep them motivated. So they do need 24/7 helplines. If you cannot provide your own, if you have a reasonable number of patients with type 1 diabetes, please do create a 24/7 helpline. If you do not, then hatch on to another person's helpline wherever they exist. And WhatsApp groups is a great way to communicate because young people, they can share their reports, you can up titrate their doses, down titrate their doses, give them education. You can do a service like call your buddy because they're depressed. In middle of the night, the child's going to be depressed. Coming from school, somebody didn't speak to you, they're getting depressed. There's so much of discrimination in this society. So if there's someone they can talk to, that itself is a great step from what we call a person is deviating, not taking care. So that is a time that it will help. Online meets are a great way. COVID taught us that, where we could reach the remotest of kids, because luckily, at least in India, we all have telephones today, and most of the kids are very, very savvy with phones. I have laborers' kids, I have people working in the farm, but they would sit on the in the bullock cart and they'll log in from there and attend a meet, which was really heartening in the COVID times. And we've also caught on to the online meets now, and social media is a great way to reach to them. Maintain documentation. This is something I would like to emphasize for everyone who is in type 1 care. Do document them. You have to have a registration with all the basic parameters. Do the basic investigations. If they can't afford it, do it in a free camp. Get it sponsored by a pharma company, but do it. Do the clinical workup. Document it. And this is the documentation you can use as a registry. The Indian bodies, especially RSSDI, is starting a type 1 diabetes registry, and we do need to have as many people contributing, because if we don't have our own data, we are not going to change the government policies. If we don't have numbers, then we will not have it as a change of policies when it comes to free treatment, free support, school policies, college policies. We need all that for people with type 1 diabetes. So we do need a very good documentation for our population with type 1 diabetes. Another very important point I feel is focus on the first month. The first consultation, what you say is very important. There is a very nice word which is called language matters. If somebody comes to you with type 1 diabetes and the HbA1c is 50 and the child is frail, has just come out of decay, and you say, oh my God, so dangerous, you've got a dangerous disease, that family is never going to recover out of it. It's always going to be traumatized that, oh, my kidney can get spoiled, my eyes will get spoiled. That's not what you say the first time. No matter what is the truth, you don't say it the first time. So many people feel that scaring is the best way to get into compliance. But you're talking about young people and caregivers who have to live the entire life with it. Yes, at some stage, there is an appropriate stage when we're going to talk about it. But this matters, because otherwise this person is not going to take the insulin you're giving them. You're going to say, anyway, my kidneys are going to fail. You set in a phobia, which is really bad. So the first time it's very important to bust the myths, tell them what about it, and more importantly, emphasize this insulin's not going to stop. There's no soft talk around there. Start and don't stop. Never stop. Even if you try the babas and the fakirs and the Ayurveda and the whatever you want to do, what leaves you want to take, don't stop. Insulin has to be the first month mantra, again and again repeated. Then we also have to talk to them about the honeymoon phase, because there could be a time when they will not need insulin or will need very low, and they will feel it's cured. And they will think it's because of something they did. And they're going to feel very happy and then again land in decay. So it's very important to talk to them in the beginning itself. Talk to them about the various alternative therapies. Teach them, handhold them. So take 1 month at least, or 6 weeks, whatever it takes, the learning capacity of the family, to handhold them for that 1 month before you start saying that it can be done or can't be done. Individualization, I was talking about insulin monitoring, physical activity, follow-up and investigations, emergency care, and medical nutrition therapy. All has to be given through education. It is individualized. Person in a village doing carb counting and person on a pump doing carb counting would be different, but both will be doing carb counting. That is important. It is not that you're in a village and you are illiterate, so you can't do carb counting. We'll show you how they can. So insulin regimes, again the same thing. Whether you're in a village, a laborer's kid with no money, or you have everything in the world, yet you give them a physiological insulin replacement. No pre-mixes, please. Let us spread this message wide, everywhere, from every forum. No premixes for type 1 diabetes. Only time one can even think of a premix where that is the only insulin available in a remote village to save life, till they are shifted to NPH and regular if they cannot afford analog insulins. So even if you write a prescription and you're forced to write a premix because nothing is available, write in big letters that this is temporary. Please shift to regular and NPH and use it 3 to 4 times a day as soon as possible, because this is a message that will be percolated throughout the society. How many children have lost their thriving ability because they were on premixes is something we don't even have enough records, right? Monitoring and logging we cannot do without. So it's not just taking insulin, one has to monitor. Any glucometer company will give you free glucometers. I mean, we don't have to talk about money all the time. There's so many NGOs, so many organizations. Just ask. Search on the net which is the nearest NGO. Search. Today are good times. You want to support somebody, we'll find a way to support. Right? Reach out to various organizations. At least design a minimal monitoring method. Of course, maximal would be wonderful, but if you do a minimal also, it could be something like this. It could be 5, 1 monitoring a day. It could be 2. It could be 5 monitoring a day, depending on the need of the child and availability of the strips. CGMS, even if you don't use regularly, because of course if one can use regularly, especially in small children, it would be wonderful. But if one could not use it, then at least try it once in a couple of months, because all the hidden nocturnal hypoglycemias, all the variabilities in the school, in playtime, and that is a great motivator for them. So you can use a diagnostic CGMS instead of a continuous CGMS if we cannot use it regularly. Otherwise, if we have to invest money, then the best thing to invest is on a continuous glucose monitoring, because the outcomes change dramatically as compared to any other investment in terms of technology. So there's a little child with a CGMS. So every age, I mean, this child is playing because there's a CGMS. You're not worried in the night time. You're not worried at various times of the day because children graze, they eat at different times, so it becomes difficult. So nutrition can be very simple as a balance plate. It could be, next step is to identify macros, then visual carb counting. Even a rural person can do that, then actual carb counting, and then managing your own meals. So every single person can learn carb counting if we learn it. So we should know how to count carbs. And once we do it, we find it so simple, we can teach everyone. Look at this little girl in a village and look at her plate. So a child in a village where we work would say to the mother that there's no protein in my plate. Mama, give me a egg. Now this is an illiterate family in a village, but the child knows there's no protein. So there's visual counting, visual balancing. Follow-up is a must. All guidelines are available. It's not very expensive. Not many tests are required. So 3 years post-detection or 5 years post-detection, annual, biannual. What are the tests needed? Make a list. Get them done. If you don't have the money, get them done in government hospitals, get them through various resources, through various camps. But if we don't do them, we're going to miss out so many things. For example, if you don't do a thyroid profile in a person with type 1 diabetes, you might actually miss out an autoimmune aspect which would be there. So it's very, very important to design individually that follow-up, following any of the guidelines that you would be happy to. So it's really possible. I mean, this is just one day in a Udan family. These are all low resource setting kids. But when they learn, when they get their glucometer checked, getting a clinical checkup, doing a group education, doing individual training, and all of this is happening in a low resource setup. Even the person's teaching, if you see the second photograph and you see they're sitting on the floor, the person who is teaching is a mother of a child with type 1 diabetes, and the person who is studying is also a family with type 1 diabetes. So it becomes a community, and if we want to, we can easily build that. And that is how the whole ecosystem works. So everyone can learn, even the most mentally challenged or emotionally challenged. I mean, you get both kinds of people. Somebody may not want to learn, somebody is not capable of learning, but both can learn. We just have to have different tools. Somebody can use videos, somebody can use actual demonstration, somebody can read, somebody can play games, but there are ways of teaching everyone, because there's no way out. You have to learn. There's absolutely no way out. So these are just some of the games. This is just an idea. Like board games. Children love to play board games. You make them in your own language, make them on paper in color. And they know now that if I do this, for example, if I check my sugar and it is hypoglycemia and I don't eat, you go 2 steps back, right? And if you take a correction thing, you go 2 steps ahead. And when they play again and again, they learn and they just become familiar without having been taught in a very formal manner. And these are ways you can make people do this happily. And that is very important in children. In villages, we say the insulin is to be stored at a certain temperature. You can use an earthen pot. There are many ways. This is a validated earthen pot which would cost 150 rupees. There's an inner earthen pot, outer earthen pot with sand in between. All you have to do is 3 glasses of water in a day. And the temperature is maintained below 26 degrees, which is the required temperature. Of course, guidelines are now changing gradually. A very important part of type 1 care, wherever you are, if you are a standalone chota sa clinic in a remote area, you still need peer group activity. That is the biggest motivator in type 1 diabetes. With the best of prescriptions, if we can get people together, and the moment they meet other people with type 1 diabetes, that is the time they want to do better. Till then, if I feel I'm the only one in the world, why me? And it's just too much to cope. And that is what makes things go bad. It's not always the supplies. We always say it's a poor country, we can't afford it. I have rich patients who are on pump and yet not willing. And that changed when they had peer group, they met friends who were doing better, when they went out on picnics, when they had fun, they climbed forts together. So these are 4 of my girls, and you can see their beaming smiles. They all come from very, very, very low resource setting. But when they met friends, this is on top of the Altabad fort, and that is the time they said, oh, we can also do it. And that made them use the whatever resources they had to, in a certain way. And today all 4 of them have in professional colleges doing very well. So it's still easier than done. I mean, I've said a lot of things. I wanted to emphasize that yes, we want to be physiological in our insulin regimes. We don't want to give premix. That's a big thing I would like to say. We have to monitor whatever is the situation, make it available. We have to do a follow-up. We have to do some kind of carb counting depending on the level, but enough to assist the person to titrate their doses accurately. And having all said all that, we have to educate in some way or the other, reach out for other people wherever you can, and create a peer group. When we do all this, it's not easy. Type 1 diabetes is a big calculation 24/7, yet it is possible. I have 1,000 children in villages who are doing it very successfully. If they can, we all can. So we all need to get together. If you do not have the resources, do reach out to Diabetes India, to RSSDI, to hundreds of NGOs today flourishing in the country for knowledge, for support, for medical support, for any kind of hand-holding that you need to take care of your children with type 1 diabetes. Thank you so much.
Thank you for the short, crispy talk. Even though the crispy talk has made an eye-opening to each and everyone listening, what we have to do exactly in type 1 diabetes and what's the day-to-day thing, what we learn today. So, I think any questions from anyone?
Yes. RSSDI today has many programs. If you have children with type 1 diabetes, you can write a letter. I am in part of the task force. You can write to me, you can write to Dr. Banshi Sabu. The addresses are on the website also. And there are various pharma companies who are supporting this program. And absolutely, that can be done. That's one. Otherwise, of course, there are different pharma companies who could individually support you. And there's Life for a Child program. So if we don't have a specific program for you, we can put you in part of a group as a sub-center and help you support your children. Definitely. Oh yes, please. Definitely. Do write to us. Absolutely. That is why we started this.
Just to add, we have certain NGOs also who have now come forward in supporting type 1 diabetes. Even I come from a very rural place. We have NGOs tied up with Rotary and other type of people who are ready to support free insulin lifetime. And they take the entire child and they provide free insulin. And we, like Madam said, it's to be done as a group so that they can share the things. And nowadays, more amount of vision is being thrown out.
So I would just like to add here that whenever we do ask for insulin from any NGO, any organization or the government, please ask for basal bolus. Ask for glucometers, ask for strips. Because if we don't combine this, we set a very wrong trend. Right, so people think it's okay to give a premix or okay to just give a, a conventional, because children, adolescents need the right insulin. So ask for the best. Maybe we compromise later, but ask for the best to set the trends across the country of uniformity. Right?
Still there is a huge inertia.
Yes, yes.
What you said exactly, more people use of premix and things.
So whenever you see, I would just say, whenever you see a prescription, write on the top,
yes,
no premix, like that. So it's very important to write it there. And as I think the previous we were saying about metformin, if you're doing that, write it. That's very important. The message goes across.